Good morning, kia ora. Thank you again for inviting me to speak at this conference, and it's a shame I can't be there in person with you. I'm going to talk to you today about the ever-changing world of delivery of falls prevention programs, shortcuts, misunderstandings, widening reach, and then COVID-19. I'm a professor of ageing and health at Glasgow Caledonian University, but I'm also a director of a not-for-profit training company that works in the UK and Europe, delivering training in falls prevention. I'm going to cover a few things in this talk. I will, of course, remind you just briefly of the evidence for exercise and falls prevention. And then I'm going to concentrate mostly in how that's delivered in practice, both in rehabilitation and public health environments. Unfortunately, there is a plethora of shortcuts, lack of fidelity. Are we actually increasing people's confidence so that they expose themselves to more risk? Are they even ready for that risk? What's in a name? Misunderstandings, the problems of COVID-19 and what that did to full services, and then talk a little bit about widening reach and opportunities with digital delivery. And I'll finalize just with a reminder of your role in influencing the implementation of effective programs. So first of all, the evidence. We know from Kathy Sherrington's Cochrane review that exercise as a standalone intervention reduces both the rate of falls and the number of people experiencing one or more falls, irrespective of whether they are high or lower risk of falls at baseline. It may reduce fall-related fractures, and it may reduce falls requiring medical attention. But the devil's in the detail, isn't it? Not all falls prevention exercise programs work. Not that I'm expecting you to read this, but here you've got the forest plots of the Cochrane review, and each study is on a line, and whether or not it's effective or not is down that central upright line with the crossings marked. Anything marked with a blue arrow is something that was either ineffective or increased risk of falls. So as you can see, about half worked and about half didn't. So what works best? Well, we know from sub-analysis within the Cochrane review that functional strength and balance work, and specifically the balance work should be highly challenging and strength work should be progressive. We know that we need a frequency of 3 times a week for about 2 hours in total. That can be a mix of group and home-based. We need a duration of about 6 months or more, because those are where all the effective programs lie. And that means we need a dose of at least 50 hours. And importantly, when people stop, you start seeing a reduction in their ability to correct a trip from becoming a fall. The same types of exercise, functional balance and strength, also reduce fear of falling. We know that from Denise Kendrick's Cochrane review. And there's no evidence at the moment to support physical activity. And by that, I mean leisure activities such as walking and dance, or resistance training alone. So we need that functional balance and strength, multimodal exercise to support falls prevention. Interestingly, if you look at exercise for frailty outcomes, the same thing happens. We see that review studies generally last about 6 months, sessions lasting around 60 minutes, 3 or more times a week, including multi-component exercises. We also see that when we look at sarcopenia. Efficacious programs are 3 to 6 months long, 2 to 3 times a week for 45 to 60 minutes each session, multi-component and progressive. So we're seeing a bit of a theme going on here. So I first want to talk to you about program fidelity. We know that there are effective types of exercise, components of fitness, there's an effective dose. We know that nearly all the programs had a strong behavior change support and included improving physical literacy of the people in the programs. So let me show you just what happens in one country alone. This is just an example of shortcuts in delivery. Once the commissioners get their hands on a program, they just fit it in however it fits financially. So Otago, which was, if you remember, a 1-year home-based program 3 times a week with a walking program, which included 6 home visits plus telephone calls in between. That's the original research program. What happens in the UK is they're handed a home exercise booklet and a set of weights. There's little progression and no support for the walking program. There's very little follow-up, absolutely no motivational support. And if it's in groups, it's going to be for 8 to 12 weeks maximum. More than half the class was seated. There was no referral on to other exercise opportunities. In FaME, which, if you remember, is supposed to be a 6 to 9 month program, group-based once a week, home-based twice a week or more. And we know that if it's completed for 6 to 9 months, then there's an increase in MVPA, that's moderate to vigorous physical activity. But what happens in the UK when they get commissioned? Well, they're 8 to 12 week programs. There's little home exercise encouragement, poor progression of bands and weights, and people avoid floor work because it's too much risk assessment paperwork. So these are a couple of audits and reviews by Royal College of Physicians and the Centre for Ageing Better. And sadly, what does this really mean? It means that you're not going to get an effective programme. And then you could look at the pragmatic delivery that started to happen in research. So this is where Otago has been delivered in different contexts or durations from the original Otago randomized controlled trials. So the first one I want to talk about is PREFIT. This was a very, very large study which was powered for fracture prevention. It was delivered over 6 months rather than the original 12. There was a suboptimal progression or prescription of ankle weights and an average of 5 contacts, that's home and phone calls, with a physiotherapist over that period. Or PROACT, another study which had Otago as an arm. This again was 6 months rather than 12. Again, a suboptimal progression or prescription of ankle weights and only 3 contacts over that period with a peer mentor or an instructor. What did we really see out of these two? Well, you only get out what you put into it. Neither of those had a really efficacious effect on falls. PREFIT showed a reduction in falls at 8 months, which disappeared after that. PROACT was only efficacious in people who met the prescription, which was very few people. So when is falls exercise a treatment rather than a supplement? After all, you wouldn't dream of giving aspirin just for a few weeks to prevent stroke. No, you'd give it for life. So when does exercise act as a drug? In effect, it's the treatment, and therefore we should be considering properly the dose, the duration, the frequency, and the motivational support. Well, when reduced falls is your outcome, then exercise should be treated as a drug. We need to use an effective program. We need to have an effective dose. We need to remember that if they stop, the effects will discontinue. And we need specialist exercise instructors or physiotherapists or kinesiologists in order to ensure that the prescription and delivery is correct. We know we need supervised exercise when we work with people with Parkinson's, specifically later stage Parkinson's, people with impairments following stroke, people with moderate to severe dementia, and with care home residents because of their frailty and multi-comorbidity. But, you know, one of the things that we know strongly happens in people who've had multiple falls or who are just worried about falls is that they start to change the way they move and the frequency with which they move. And this fear and lack of confidence in their balance predicts a deterioration in their physical functioning. It decreases their physical activity, both indoors and outdoors. And all of these things affect whether a person will engage or how often they engage with exercise. But exercise has a very quick effect on improving confidence, balance confidence in particular. Nearly all studies that measure it see an improvement in balance confidence within 6 to 8 weeks. So we get confidence improvement well before we've got an efficacious dose to reduce falls. The physiology hasn't caught up. And I'll give you a couple of examples of that, or an example of that. the FaME program, Falls Management Exercise, one of the efficacious programs in the Sherrington Review. When it was first looked at in very frequent falling older women, people who had a history of 3 or more falls in the past year, we know that the 9-month program reduced falls by about a half, pretty good. But during the intervention, the exercises had slightly higher increased number of falls, less likely to be injurious, but they were falling more. And they put this down to the fact that they were more confident and therefore went out more and exposed themselves to more risk. Interestingly, this was reproduced, the FaME program was reproduced in sedentary older adults, so not those at very high risk. This also reduced falls after a 6-month program, again by about a half. But this time during the intervention, there was no difference between the Otago group or the FaME group and the control. So in other words, if people aren't particularly frail, then you don't necessarily see this increased exposure to risk or this increased number of falls. But the frailer they are, the more likely you are to see them increasing their exposure to risk before they're actually ready. Picked up a lovely quote here: "What I lack in skills and ability, I more than make up for in confidence." And that might well be the problem. Interestingly, this was also seen in another study that wasn't exercise related. This was a study looking at providing single lens distance glasses to regular users of multifocal glasses in order to reduce falls, because there's a strong link between bifocal glasses and falls. If they were active or transitioning to frailty, there was a reduction in falls by changing their glasses, a 40% reduction, pretty good. But if they were frail, and particularly if they spent more times indoors prior to the intervention, and after the intervention they spent more time outdoors, there was a significant increase in falls outside. So they weren't seeing the risk or being able to cope with the risk of pavements or outdoor walking. So in this instance, again, frailty led to more adverse events because of confidence. After all, they've assumed they'd changed their glasses and that was going to reduce their risk, because the study was about risk and glasses. So moving on to prevention, strength and balance, that message that we need to prevent falls by maintaining better strength and balance as we age. A great message, and I'm very pleased it started to get out there, but by goodness, there's a lot of misunderstandings around. Here's a few of them. Chair-based exercise does not reduce falls. The amount of programs in the UK that are chair-based that advertise that they are falls prevention is ridiculous. Improving strength and balance does not mean you will reduce falls. We know that from the multiple number of studies in the Sherrington Review that didn't have an effect on falls, but had an effect on proxy markers of strength and balance. Doing a couple of exercises that appear in the Otago program within your program won't necessarily reduce falls. The Otago program is a set program with a set progression, and in its entirety, it reduces falls. Picking 4 or 5 of the exercises from it and adding it to another program is not necessarily going to reduce falls. Gentle exercise will not challenge someone's nervous and muscular system enough to lead to a physiological and neurological change. Remember, we need a training effect to actually see a change. And older people will engage if they know why they're doing it, not the whole program itself, but what does each exercise do to help them in everyday life? What should it feel like? What should an actual training effect in strength feel like? The muscle getting warmer, shaking a bit, that means there's a training effect happening, and it's important for them to understand that. It's important for them to understand they need to feel wobbly in order for the nervous system to improve their balance. And of course, with age is a vast array of ability. It depends on how we've aged and how successfully we've aged. We can age like the lady on the top right, age 82, resilient, obviously has pretty good fitness and strength and balance. Or we could age in the bottom right corner. The lady's also 82, as you can see, quite frail, requires supervised exercise. And this is the important thing. Older people are not the same. And therefore, the sort of programs you provide in order to either support improving strength and balance or to reduce falls has to be appropriate to their ability in the first place. And in terms of promoting physical activity to reduce strength and balance problems in the future, not all physical activity even works on strength and balance. So, remembering that things such as walking do not improve bone health, are unlikely to improve muscle function too much, and there's not really any effect on balance unless you're talking about Nordic walking. So we need to remember that those at high risk of a fall should not be pointed in the direction of just doing general activity to improve strength and balance. They need to be pointed in the direction of an efficacious program. So what about another misunderstanding? What's in a name? Well, here I just show two adverts for Otago exercise programs. These are easily found on Google Images. So the first one I thought was fascinating: gentle exercise. Gentle exercise to help you keep fit, flexible, and fabulous. Well, this is great, and it may well be that that's attractive to an older person. But I hope the minute they get there, they appreciate that it isn't gentle. And in order to progress, they need to progress those ankle weights. They need to feel really quite wobbly in those balance exercises. Neither image on either of these two adverts is an image of an Otago exercise. So we could argue there's branding involved here. Let's at least show them what they're going to take part in rather than what they managed to get off Google, I guess. And neither are really showing the people who might benefit from Otago exercise. We know that Otago is efficacious for the over 65s, but is far better for those who are over 80, and there's certainly a bigger reduction in falls risk. And that's partly because the Otago exercises are relatively static, not too dynamic, and can be done safely at home. That's why they were developed in that way. Therefore, they don't push people as hard as other exercise programs to reduce falls, and therefore work better in people who are at a lower level of ability in the first place. What about this one? This one's fascinating. So falls prevention highlighted. It's a national charity in the UK. And when you read the detail, these falls prevention classes include chair-based exercise, Tai Chi, and a walking group. Well, I'm glad they got Tai Chi there because there is evidence for that. But chair-based exercise does not reduce falls, even if it does reduce some risk factors. And walking does not reduce falls. And if it's brisk, it might even increase risk. So let's actually give the right messaging and the right names to things so we can provide physical literacy to the older adults we work with. If it works, replicate it. The amount of times I hear physiotherapists around Europe and the UK saying, can't afford the ankle weights, they cost too much, our service doesn't have that money, we can't afford to give one per patient. But even then, even if you got them, can they even put them on? Do they have the flexibility to get down and put them on themselves? Do they fit? Cheap ankle weights have always got very small coverings, and therefore if someone's got edema in the ankles or swollen ankles, then often they just don't fit, they fall off, or they rub and cause problems to the skin. Are they adjustable? And that's not just in terms of size or width, but also in weight progression, because it's all very well a service buying hundreds of half kilo and 1 kilo weights, but where's the progression in that? After all, in the original Otago program, most people got to 4 kilos and many got above that. So weight progression, ideally you want to use a set of ankle weights that you can just go along on a home visit and top it up and make them a little bit heavier for people. There are a couple of recent studies where progression of ankle weights was minimal compared to the original Otago randomized control trials, as I mentioned before, PREFIT and PROACT. And so I think really we just need to consider two things. We need to consider the use of them because they are an integral part of the Otago program. And we also need to consider who is encouraging that weight progression, and I'll go on to explain more. So, what level of supervision is needed? Just want to explain a couple of studies which have showed the importance of supervision. A particular exercise program by FaME et al., they applied the frailty index to participants in this program. They were working mostly unsupervised at home. And those who were categorized as frail had a relative risk of 2.95 for a fall versus those who were pre-frail, which had a much reduced relative risk. So in other words, the adverse events were higher, considerably higher in those who were frail when unsupervised. Or the home exercise program by Kathy Sherrington as well looked at exercise on discharge from hospital, home visits to check up on both ability to do it and progression of weights, etc., and progression of exercises, huge improvements in mobility, which is fabulous, but also an increase in falls. And supervised exercise is much more effective than unsupervised exercise in Parkinson's. In fact, in people with advanced disease, minimally supervised exercise may actually increase the risk of falls. And then, of course, you consider effectiveness again. I mentioned PROACT earlier on. So not only was there not a good progression of ankle weights, but the visits and calls for progression and motivation were by peer mentors. So other older people, as opposed to by the trained postural stability instructor who had started them off and assessed their first level of starting exercise. And it wasn't effective in PROACT. So a mix of perhaps non-motivational support, or the peer mentors just basically not pushing people to increase the ankle weights over time. So suitably trained professionals are important. Depending on the level of risk, frailty, condition of health, then essentially we would be looking at physiotherapists, kinesiologists, or clinical exercise physiologists delivering the program in most research studies. One or two have had specialist exercise instructors who've had 200 odd hours of training on working with older adults with frailty, with multiple comorbidities, and with specific exercise programs that reduce falls. And on most of the people on the left-hand side of this slide, so post-hip fracture with Parkinson's, cognitive impairment, stroke, care home residents, then most of those would need that kind of specialist instruction in order for safe tailoring and progression of exercise. For those who are transitioning to frailty, then yes, your personal trainer or your normal exercise instructor working with the general population would still be able to do strength and balance training. But as soon as that person required some support in their balance work, then essentially they should be moving on to a specialist exercise instructor. So that's the difference between prevention and management. And then, of course, COVID hit. And boy, did it hit. And we're all in various stages of it still hitting. The social restrictions posed by COVID, however, of course, were helping reduce the spread of disease and the mortality that was associated with COVID. And in particular, as you're well aware, older adults and those with multiple medical conditions were expected to shield and keep well away from the population during these times. So the immediate impacts of complete lack of physical activity in comparison to what people were doing before is deconditioning in terms of cardiovascular, respiratory, and metabolic levels in the body. A loss of strength and balance, depending on how long you're avoiding activity for, because we're all well aware of deconditioning in hospital, for example. Insulin resistance and increased fat mass, and an increase in social isolation and worse mental health and well-being. So not straight away, but we certainly might expect to see an increase in nearly all the things I have pointed out on the right. Over time, an increase in falls, depression, type 2 diabetes, CVD, and musculoskeletal problems. The large decline in physical activity wasn't just, those that were going to exercise groups or programs, but also just the huge decline in incidental physical activity. Active travel to work, incidental activity to and from the shops, to and from a favourite volunteering opportunity or group, leisure and sport activity all ground to a halt. Essentially, the access to healthcare as well, if you consider that all falls exercise services were paused as well, means that we would expect an increase in falls and frailty over the next year, 2 years, and potentially for much longer after that, if people don't get their levels up, their physical activity levels up again. And we all know the effects of sedentary behaviour. There's been a huge amount of research on sedentary behaviour in the last 5 or 6 years, showing it to be an independent risk factor for health, irrespective of the amount of moderate to vigorous physical activity that people do for many conditions. And in particular, I just draw your attention, a reminder that if people who spend more time sedentary are more likely to have reduced muscle strength, reduced bone density, increased frailty, and increased falls. So, for example, the recent JAGS paper by Rosenberg has shown that those with the highest quartile of sedentary behaviour had a 26% higher risk of falling relative to the lowest quartile. So sedentary behaviour is an issue. And boy, were people sedentary, certainly in the first beginning parts of COVID, when there was full lockdowns. And of course, many people are back in those again now around the world. So here's a report from a local charity in the UK. 26% are unable to walk as far as before. 18% felt less steady on their feet following the first 3 months lockdown of COVID in the UK. They had an average duration of strength and balance activity declining from 126 to 77 minutes per week, according to Sport England, which did a survey. And of course, this is surveying older adults and adults who are computer literate and take part in online surveys. And some modelling done by Public Health England as a result of the reduction in physical activity. And you can get hold of that document from gov.uk, COVID-19 wider impacts on people aged 65 and over, where they have modelled that the reduction of strength and balance activity in that first 4 months of COVID means there'll be an increase of at least 250,000 falls in 110,000 people in the next year. And that will cost 211 million per year over the next 2.5 years, and will go up unless we can increase the physical activity of our nation as quickly as possible. So one thing that came out was I wrote a little article in The Conversation, which is a supplement to the Times. And it's really interesting because I just basically wrote the article about why it's important to stand on one leg for health. And it's fascinating how many people responded to that, and particularly how many said they just can't do it. They can't do it anymore. And of course, my answer to that is practice makes perfect. But we know that one leg standing time is a predictor of falls. We know it also is associated with increase of incident fractures from a very large study looking at bone mineral density and clinical risk factors for fractures in Sweden. And we know that a one leg stand time of less than 10 seconds is associated with an increased risk for instance hip fracture, and in fact, almost any type of fracture. So we want people to have a certain level of static balance in order to reduce not only their risk of falls, but also their risk of fractures. How do we find those? How do we find those people that can't do that? Well, it would be lovely if all GPs measured it. After all, it's only 10 seconds. But just to give you an idea, in the UK, we for some time have been running, these were face-to-face pre-COVID, functional fitness MOTs. So an MOT is actually stands for Ministry of Transport. And in the UK, you get your car checked every year to see its it's okay, it's roadworthy to be on the road, and you get a little ticket to put in your car. So we would run these little checks where we had a normative data set for 9 functional tests, and essentially we would measure them on each of those, have a conversation, discussion about capability, opportunity, and motivation to be more active, to improve their functional abilities. But of course, then COVID hit. And so we had to turn that around to an online version where people self-assess their function and physical activity at home. And then there's an online conversation about capability, opportunity, and motivation to be more active, and lots of information about local opportunities, both online and face-to-face as COVID recedes. And online is a very important thing. And that's my last real point, which is widening reach. So essentially, we know that we now, especially post-COVID, are going to have a tsunami of rehabilitation needs coming our way. And therefore, we need to ensure we can get out most effectively to people and essentially reach as many people as we can in a short period of time. There's many positives for online delivery: extending the reach and the numbers, saving travel time, patients and providers, by the way. Just to give you an example, but if I wanted to take part in a falls program, my nearest group is 53 miles away. So I'm not going to drive there to do that. And I'm more likely, as I'm digitally literate, to engage in something online if that was offered to me. Potentially it's cheaper to deliver because potentially you don't have travel costs and travel time. You can run many more in a day, and on the same salary of whatever person you're employing to do it. We know it can enhance group sessions for increased dose. We know that this could potentially provide a choice of times, days of the week, even level of challenge, because many services don't run that regularly. People can't necessarily attend on the day or time of the set program. And often they might go and find that particular group too easy or too hard for them. So the level of challenge is an issue. It could potentially be on demand whenever they can fit it in and in the comfort of their own home, although not necessarily in the particular exercise that the lady's doing in the picture. And of course, with COVID, there was a huge growth in online accessibility. Some good, some not so good. I'd unfortunately like to say, unfortunately, most was not so good. I don't know if you've watched some of them, but my goodness me, the instruction is terrible. They don't make any thought or consideration to support options. Half the time, there's not even a decent warm-up. It's really quite scary what appeared to all over the place in the UK, certainly. And of course, I've picked these up from YouTube, so they're all over the world. I mentioned I was part of a not-for-profit training company, and one of the things we did was to, on the first day of lockdown in the UK, was start providing Make Movement Your Mission, essentially to try and support the instructors that we knew would not be able to run their falls programs during the COVID lockdown, and to try and stop their participants from deconditioning so much that they couldn't actually just go back and join in again when they could set up. So that's what we set off initially to do. Here we are 21 months later, still doing this because COVID hasn't really gone away, and most full services are still not running in the UK. But Make Movement Your Mission essentially is 3 times a day, 15-minute movement snacks, 8 o'clock in the morning, 12 noon, 4 p.m, 7 days a week, 365 days a year. So we even had a chat and caught up with people Christmas Day, Boxing Day, New Year's Day, etc. And as you can see from the images, it's from front rooms, gardens and hallways. The instructors, the 3 instructors that deliver it, are all falls prevention trained exercise instructors. And essentially the whole point here is just to try and get people to stay as active as possible. There will be a publication on the evaluation of this fairly shortly, I hope. But it's still there if you want to point anyone in the direction. We've got quite a few people from Canada, Germany, across Europe. It'd be lovely to have some people joining us from New Zealand and Australia, although I appreciate the time difference means they might be more likely to catch up with the YouTube rather than the live Facebook ones. Anyway, back to online delivery. The frailest are least likely to engage. We have problems with accessibility, reliability of Wi-Fi, the platforms. If you just look on the right, there's one example of some online rehab. Well, it's pretty hard to see if their technique's any good, what their support options are like, if they are at risk of a fall, even what they've got on their feet. So we've got issues about pre-exercise assessment beforehand. Do they have visual or cognitive impairment that's going to interact with their usage of the platform? What support options have they got at home that's safe? And also, how are we going to assess their current ability to allow tailoring and progression? Observation is an issue. The more people you have online, the harder you can see, because they get very small and you certainly can't correct technique. You could think about pre-recorded library with progressions, but again, behavioral support, you know, the education part of delivering a session in a group or sitting with someone on a one-to-one basis often gets lost once you get to these very large groups online where everybody's trying to just connect. And then, of course, very few of these have been evaluated, only in terms of numbers of people going, not in terms of outcome. So adding digital solutions to the home exercise message is important. Hopefully we will get back to face-to-face work, but the digital solutions to top up dose and particularly home exercise is important. And also the potential of maintaining contact between the patient and the therapist or instructor is also really useful to think about. There are a number of currently recommended strength and balance apps. I would point in the direction of Lisa McGarrigle's paper in BMC Geriatrics, Map the Apps, because all of these are available online and have got some research in terms of efficacy as well as usability. And there's a new one that's just being looked at in the UK at the moment, which is two apps. The patient has one, the professional has another, which allows constant prompting, motivational, bespoke feedback prompts. The professional knows how often someone's done them. And essentially there's some great work on this showing huge benefit to adherence and dose with this app. So we just need to be thinking about driving quality provision. Again, in the UK, because partly we've been running full services now for 20 years and they're still a bit of a shambles, Public Health England have been producing a whole series of documents over the last 3 to 4 years, trying to push for fidelity to known efficacious programs, providing quality markers for service improvement audits, consensus statements for commissioners. We've got implementation toolkits, FaME being one of them, and this literally has everything from how to write your funding bid in the first place, how to cost up a good program with proper pre-exercise assessment, motivational support, social support equipment, and how to evaluate your program and quality assure the provision. And then, of course, you've also got two good implementation manuals also from the CDC on effective falls prevention interventions. We need to make sure we consider the physical literacy of the people we work with. Let them be the biggest push for change. We need them to know if it doesn't challenge you, it won't change you. We need to know that you get what you work for, not what you wish for. So you have to put some effort in for the body to actually change. We need to know that it's a use it or lose it, literally. So the minute they discharge from the falls program, they will start losing their regained skills, and therefore exercise really should be for life. And we need to ensure that they know that they're getting the right prescription. So if they happen to be in a program that's only 8 weeks long and discharges them, they need to know to be able to put their hand up and go, why are you discharging me, without other thoughts about where I can go. What comes easy won't last. What lasts won't come easy. So my final thoughts, in terms of prevention, it'd be really important to identify locally which adults have frailty and which need support to increase physical activity, particularly post-COVID. People should be mapping local and online provision with the level of training of the person delivering that to ensure that they have a suite of opportunities to offer people when they find them. The promotion and increased availability of strength and balance activity for older adults should always involve a gradual increase in activity in order to reduce falls risk and enable safe and confident participation in other forms of exercise and physical activity. In terms of efficacy, the training of exercise instructors in known programs and in working with frailer, high-risk or multi-morbid older adults will allow a seamless transition to community-based programs following rehabilitation. More importantly, it will allow a decent, efficacious program to be delivered rather than everyone transitioning to a lovely seated, gentle exercise program. There needs to be a choice of group on home or setting and exercise type within the known efficacious types of functional, balance and strength, Tai Chi, some strength training work in there, and multimodal activities. We know if we offer choice, we will see an increase in adherence. We know that increased supervision and support gives better results. Smaller sizes of group gives better results. And in terms of management, please ensure that the multidisciplinary and community-based programs are based on proven programs, have appropriate dose. That's going to be where the biggest problem is, I think. Have good liaison with other exercise opportunities for maintenance at discharge, and they evaluate and quality assure their provision. So I'll finish there saying, please, you know what works. Let's stick to it. Let's not cut corners. Let's not cherry pick. And just a prompt as I finish that coming soon are the World Falls Guidelines, global guidelines for falls, and keep an eye out for those. Thank you very much.